It must be remembered that most action spectrum have been performed on thin layers of cells. It is possible that the optimum wavelength under these conditions might not be the optimum wavelength for deep tissues. A longer wavelength that penetrates more deeply into tissues might produce the best effect in deep tissues, even though the wavelength was not the most efficient in the thin layer of cells. To quote a review by Calderhead, to sum up, the wavelength of a therapeutic source therefore has a double importance, namely to ensure absorption of the incident photons in the target chromophores and to be able to do so at the depths at which these chromophores exist. The wave band in which the wavelength of the incident photons is located determines not only which part of the cell is the target, but also the primary photoaction. Wavelength is thus probably the single most important consideration in phototherapy, because without absorption, there can be no reaction. Another point discussed in his review is that two different wavelengths might produce a better effect under certain conditions, such as wound healing. Calderhead reports that mast cells and neutrophils and macrophages are the first cells to respond to a wound. And these cells respond most efficiently to 833 nanometer light. In contrast, fibroblasts, which are involved somewhat later, respond better to 633 nanometer light. The suggestion has been made that it might be better to irradiate first with 830 nanometer, followed by 633 nanometer, and then again with 833 nanometer light to activate the myofibroblasts. The multiplicity of cell types and tissues and the concept that they may respond better to different wavelengths does complicate the phototherapy of tissues. It's just one more thing to keep in mind when planning experimental and clinical trials. The requirement for a good paper on photobiology requires that you specify everything about the light source, the wavelength, the dose, the area of exposure, the time, and so forth and so forth. There are published papers, experimental, which were conducted with good scientific methodology, but they did not mention the characteristics of the light source, and in some papers I've seen they didn't even mention the light source at all. Such a paper is totally useless. This is like describing a new cure for cancer without mentioning the name of the drug that you used in the clinical study. So many acronyms are present in low-level laser therapy that it is confusing to many people. And I would suggest that the preferred terminology would be low-level light therapy, because lasers just produce light. And the preferred term would be phototherapy. The wavelength of light produced by a laser must be specified throughout the text of the article in place of acronyms like HENE laser. Also, a laser should be chosen for the wavelength of light that it produces, not because, and I quote from a published paper, the selection of such a laser for therapeutic use was based upon its safety and commercial availability. What happened to wavelength? This is another example of bad science and bad reviewers. Even with a proper wavelength and dose of radiation, phototherapy will not be effective on every system and or situation. The magnitude of the phototherapeutic effect depends upon the physiological state of the cells at the moment of the irradiation. For example, when irradiating fresh wounds, the effect of the radiation can be minimal or non-existent. This happens when cellular proliferation is active and the regeneration of the tissues is occurring more or less at the normal rate. Light will only stimulate cell proliferation if the cells are growing poorly at the time of the radiation. If a cell is fully functional, there is nothing for radiation to stimulate, and no therapeutic benefit will be observed. An analogy would be that patients would show no beneficial effect of vitamin therapy if they already received an adequate supply of vitamins in their diet. It should be cautioned, however, that an excessive dose of radiation can be detrimental. Thus, at the proper dose of radiation, there can be a stimulation of growth, but at higher doses, an excessive amount of synchron oxygen may be produced, and the chemical action could be detrimental to cells. Another reason for determining an action spectrum. More and more papers are appearing in the light therapy literature using non-laser light sources such as LEDs. And as with laser studies, all the characteristics of the light emitted by these LEDs must be specified if a paper is to be useful. In conclusion, phototherapy, whether using low-intensity radiation of the proper wavelength with a laser, an LED, or a filtered incandescent lamp, can be beneficial in a number of clinical situations, from pain remission to wound healing. Unfortunately, the absence of this type of phototherapy from the mainstream of medicine makes it currently unavailable to patients who could benefit from it. The absence of this type of therapy from the mainstream of science and medicine is because so many of the studies have been conducted without proper scientific methodology and performed by people who lack an understanding of the properties and biological effects of light. This talk is a plea to scientists, physicians, phototherapy groups, societies, journals, to raise the standards of running and publishing experiments and clinical trials by learning the basics of photobiology and thereby accelerating the acceptance of low-level light therapy in science and medicine. Great progress has been made in this direction in the last 10 years, but we still have a way to go. Thank you very much for your attention.
Thank you for the wonderful presentation, Dr. Smith. Are there any questions and comments from the audience?
Leave it on.
Yes, Longo.
Congratulations for your exact exposition of the situation.
I mean, I didn't insult you?
Yeah, exactly, I agree. But I prefer to speak about non-surgical laser therapy.
Non-what?
Non-surgical laser therapy and surgical laser therapy. Not low-level, mid-level laser therapy, low-level laser therapy. Because low-level is, the parameter of low-level is the dosage. But often dosage, total dosage is not low-level, is high. So low-level laser therapy is for low-level medical doctors. And the second comment is a general comment. All your exposition is based on the study of the cells on cultures. But human body
that's not true.
Is the natural. We have 50% of cells, but we have 85% of water, and then a lot of energies with exchange of energies with between in the body and out of the body. So in clinical practice, we can use laser on millions of different cells contemporaneously, not one cell for time. This is one of the difficult for the exact dosage of their radiation in vivo.
Yes, the tissues are certainly more difficult to do proper dosimetry on than a single cell layer, but the principles are the same. The first law of photobiology is still true for I don't care how deep you go in. You can't ignore that. Photobiology is photobiology. Light must be absorbed. It's all the same whether you have one cell or you have 2 inches of tissue. And that must be remembered by everybody, that tissue, it doesn't change the rules of photobiology. It makes it more difficult, but it doesn't change the rules.
Any questions, comments?
Turn it on.
Thank you very much.